Dear participants, thank you for connecting to today's webinar on complementary feeding in emergencies. We will take a minute for other participants to connect. We will start right after. Thank you for being on time. Going to start now. So welcome again to all the participants who are joining to our last webinar of the infant and young child feeding in emergencies for Latin America and the Caribbean. Today's session will be focused on complementary feeding in emergencies. Next slide, please. So today we have simultaneous interpretation. If you want to hear or to change the language, please click on the icon interpretation available at the bottom of the screen. Chers participants, merci de vous être joints à nous ce matin pour la dernière session de la série de webinaires sur l'alimentation du nourrisson et du jeune enfant en situation d'urgence, préparée spécifiquement pour l'Amérique latine et les Caraïbes. La session d'aujourd'hui sera présentée en anglais, mais nous avons un service de traduction simultanée en français. Vous n'avez qu'à cliquer sur le bouton « Interprétation » en bas de l'écran et choisir la langue de votre préférence, dans ce cas-ci le français. Merci et bon webinaire. I'm going to now continue in English. So next slide, please. So today we have a team of facilitators. For those who have joined the previous webinars, you know already as well. So my name is Yvette Fauch, nutrition specialist. I'm working at the UNICEF Regional Office for Latin America and the Caribbean. Also with us, we have today Patricia Dominguez, nutrition consultant, also at the UNICEF Regional Office for Latin America and the Caribbean. Andrea Garcia, senior advisor in emergency nutrition at Save the Children. Diana Albino Pena, health and nutrition officer from UNICEF Brazil. Today we'll have a case study on complementary feeding in emergencies from Brazil that Diana will present. So we welcome her warmly today. And we count with the technical support of Sania Sekvic, Program Officer, Technical Support Team, Global Nutrition Cluster Technical Alliance. Next slide, please. So today's webinar is jointly organized by the UNICEF Regional Office for Latin America and the Caribbean and the Global Nutrition Cluster Technical Alliance. So the Alliance, as it is known, is an initiative for the benefit of the nutrition community and affected populations to improve the quality of nutrition in emergency preparedness, response, and recovery by providing technical support through multiple channels. So this is who we are, and we also have our supporting donors in this slide. Next slide, please. Okay, so as I said at the beginning, today is the last webinar of the webinar series, and it will be focused on how to support complementary feeding in emergencies, meaning how to support the feeding of children 6 to 23 months in emergency situations. Next slide, please. Okay, so why are we focusing on the first 2 years of life? This is a very vulnerable period where infants and young children have an immune system that is underdeveloped or under development. These 2 years of life are a period of rapid physical growth and accelerated mental development. And it is a window of opportunity to build lifelong health and intelligence. In this period, the brain grows more quickly than any other time in a person's life. So this is the right time, the perfect time to receive the right nutrients to feed brain's rapid development. So the right nutrition and care during this period influences whether the child will survive, especially in challenging circumstances such as emergencies, and his or her ability to grow, learn, and rise out of poverty. So overall, it contributes to society's long-term health, stability, and prosperity. And this period is therefore the foundation of child's health development across the lifespan. Next slide, please. And we know that feeding practices face challenges in emergencies. So in emergencies, we see populations being displaced. We see basic services being interrupted. So there's a loss of livelihoods and crops, limited access to food, health services, water, loss of income, hygiene and sanitation conditions being affected, and of course, disruption of health, nutrition, and feeding practices. So this compromises the dietary intake of these infants and young children, and it leads also to increased risk of diarrhea, and pneumonia in general, a higher risk of infectious diseases. That leads to malnutrition, and malnutrition can potentially lead to death. Next slide, please. So the objectives of today's webinar is to strengthen the technical knowledge and capacities on infant and young child feeding emergencies of organizations involved in responding to emergencies in a region, Latin America and the Caribbean. The target audience we're aiming at are government institutions, NGOs, UN agencies, and emergency coordination platforms, among others. The format, so we have tried to divide the different sections of this webinar into why, what, and how. So why, to explain the rationale of the interventions and practices that are being promoted in emergencies. What, so going a bit in depth regarding the interventions and our practices. And how, to explain the steps to take during an emergency response. Next slide, please. So again, today is on complementary feeding in emergencies. Next slide. So it will be on what is complementary feeding, what are the current complementary feeding practices in Latin America and the Caribbean, what is the complementary feeding period, so important, what are the challenges to complementary feeding in emergencies, how can complementary feeding in emergencies being supported, and we'll have a case study from Brazil. Next slide, please. Now I'm going to give the floor to Patricia Dominguez, who will explain what is complementary feeding. Patricia, over to you.
Thank you, Yvette. Good morning, thanks for joining us today. I will start with some key concepts about complementary feeding, and the key question is, what is complementary feeding? Complementary feeding is a process to introduce food from the age of 6 months when breast milk is not longer sufficient to fulfill the requirements of the child. I would like to highlight that complementary feeding is a process that includes different aspects: frequency, quantity, quality of food, but also the relationship between caregivers and children, or responsive feeding. The early, late, or inadequate introduction of complementary food put the child at risk for no longer properly grow, as well as of suffering malnutrition and other nutritional deficiencies. During emergencies, IYCF practices have more barriers than in normal context situation, and in emergencies, the goal is guaranteed two fundamental humanitarian principles: no harm and save lives immediately, plus prevent malnutrition. Next, please. What should children eat? Basically, the food that help to fulfill the nutrition gap after 6 months. That include breast milk, diverse and nutrient-dense foods, food rich in key micronutrients like iron, zinc, and vitamin A, animal source food, fruits and vegetables, fortified foods, and supplements. What kind of food should be avoided? Low nutritional value, as sugar meals to prepare home, and this is a key point. What should not eat? Now we will talk about this point in the next slide. About dietary diversity, if complementary feeding is inadequate, the risk of suffering malnutrition and micronutrient deficiency is increased. About dietary diversity, the recommendation is children need to consume food from at least 5 of 8 group recommended, as you can see the list in the slide, and breast milk is one of these key groups. This is the international recommendation is at least 5 of 8 recommended groups. The next, please. This is a summary of complementary feeding guidelines that will discuss a timely introduction of first foods, age-appropriate meal frequency, age-appropriate amount, age-appropriate consistency, safe preparation, storage and use, responsive feeding, and feeding during and after the illness. Next, please. About the time, after that 6 months of age, the children's nutritional requirements are not filled from breast milk. Complementary feeding should begin at 6 of all. Why? Because at that age, the nervous and digestive system are ready to receive and process other foods. The mouth has developed enough to breathing and chewing, and the child behind to control the movement of tongue to smell and ingest foods. Next, please. We will talking about adequate. And adequate, good complementary feeding depends not only of the type of food that gives a child, but also on how, when, where, who feeds him. And feeding with love is important for the social and emotional development of the child. Adequate refers to the frequency, amount, type, consistency, and other in order to complementary food should be introduced according to the child age to prevent feeding problems and promote the growth. Next, please. About the frequency, the amount recommended vary depending on the child are breastfed or not breastfed. For breastfed children, should be fed at least 2 meals from the age of 6 months and at least 3 meals from the age of 9 months. For non-breastfed children, should be fed at least 4 times a day. Next, please. Okay, about amount. The quantity of food should gradually increase according to the age, from the few spoons at the age of 6 months to a full cup by the 2 years of age. And this is a general recommendation. We are talking about consistency now. Next, please. When food of inappropriate consistency is offered, it is likely that the child will not be able to consume sufficient amount to ensure its growth. Should transition from the soft or smash to semi-solid to solid foods consumed by the family by the time at the 12 months. To the consistency recommended are from 6 to 9 months, pounded porridge soft of 6, from the 9 to 12, chopped or cut into small pieces, from 12 to 24, chopped slices or whole. And next, please. Hygiene and safe water are critical to prevent diseases, especially during emergencies. And this is required close collaboration with other sectors, like WASH, for example. Meals should be prepared and filled with clean hands and dishes, served with safe drinking water, and stored safely away from any focus of contamination at an appropriate temperature. This is key to protect health in this critical context. Next, please. Responsive feeding is a key part of the complementary feeding and refers to the ability to caregiver to notice, understand, and respond properly to to child's chance in a timely and proper manner. Consider the moment of eating is a space of learning and love, not just to food. Feeding. Always consider meal times as learning moments that helps develop the child's skills. Responsive feeding has 4 stages. The child gives signals for hunger or satiety. The caregivers recognize the signals. The caregivers respond appropriately. The child experiences caregiving response. Some of the child signs of fulfillment are turn the head away from the food, refuse food, or eat slowly. And it is important, if the child shows signs of fulfillment, do not force him to eat and wait for the next meal time. Responsive feeding teach baby to self-regulate food intake and prevent under and over nutrition. Next, please. Feeding during and after illness. This is a point so important during emergencies. Consider that the context, in many cases, the child are sick. With sick children regularly, they have little appetite. And the recommendation for parents is give a small amount of food more frequency, patience, and a lot of love. Encourage the mother to feed slowly, with patience, and sharing the child to eat, but without forcing. In this context, the key is the increase the times or the meal times, but in less quantity if the child requires. Next, please. About monitoring. These are some key indicators about IYCF practices. And the key is the minimum acceptable diet that includes quantity with minimum meal frequency and quality with minimum diet diversity. This is important to have a follow-up during an emergency and in normal context, because measure the quality of the diet for children. Next, please. There are some special recommendations for children non-breastfed, and these include extra water, food rich in essential fatty acids and iron, and milk and complement 4 meals a day. This is the general recommendations to fulfill the requirements with non-breastfed. Next, please. This is a point that requires special attention. What should be avoided? Food high in sugar, salt, and trans and saturated fats. And why? Because these inadequate foods can't establish lifelong taste preference and contribute to overweight and obesity. Inadequate level of sugar and unhealthy fat can also found in some commercial foods for children. And finally, next, please. The counseling is part of complementary feeding interventions. During the counseling, support is provided so that caregivers know how to feed young children following the recommendations. It is an interactive process to help and help the mothers to address any challenge feeding the babies. And this is important to, okay. This is the important points about give a complementary package of complementary feeding includes foods and counseling. And thank you for your patience. Thanks, Yvette.
Thank you, Patty. Okay, so now we're gonna go to the next session. So what are the current complementary feeding practices in our region? Next slide, please. Okay, so here we can see the percentage of children aged 6 to 23 months fed different food groups. So this is data from 2018. So what we can say on this slide is that 30% of children aged 3 to 23 months in a region are not being fed the much needed nutrients from animal source foods. And 20% of these children are not being fed any fruits or vegetables. So by not being fed with animal source foods or fruits or vegetables, children are missing key nutrients such as iron, zinc, vitamin A that are really needed for their growth and development. Next slide, please. Here we can see the percentage of children eating at least 5 out of the 8 food groups. So the percentage in each country where children this age are fed the minimum dietary diversity. So we see, we see the different percentages. Although in the region, 60% overall are being fed the minimum dietary diversity. This is better than the global average, that is 29. However, our regional percentage is hiding national disparities. For example, we can see that in Haiti, only 19% of children aged 6 to 23 months are being fed the minimum dietary diversity. And we can see here the different percentages in different countries. And the biggest, let's say, dietary diversity in our region is Peru, with 83% of children eating at least 5 out of 8 food groups. So overall, the conclusion is that 2 in 5 children do not eat foods from the minimum number of food groups in our region. Next slide, please. And one of the main findings as well is that the youngest children have least diverse diets. So here we can see the percentage of children aged 6 to 23 months fed food groups. And we can see that in blue, so children 6 to 11 months are being fed, the diversity is lower than that of children aged 12 to 23 months. So in general, children 6 to 11 months are eating less diverse diets compared to children 1 to 23 months of age. Next slide, please. This slide is showing the same, but only a bit different. So the youngest children have the least diverse diets. Here we can see that only 46% are being fed, or children 6 to 11 months are being fed minimum dietary diversity. However, when children start eating soft, solid, or semi-solid foods at 6 months, they need nutrition safe diets with a range of nutrients to be able to grow well. Next slide, please. Here we're showing some of the struggles or challenges faced by lower income families. These are results from a global study, so not specifically from a region, although a region was also taken into account in these results. So families, especially lower income families, struggle to find access and afford nutritious food for their young children. The 2 main barriers are affordability. So food is expensive, but also time pressure. Then comes availability, knowledge, preferences, relationship, and the support they have to fill children, access, as well as employment. Next slide, please. And here we're also seeing some, well, these are global results. Some children are fed processed foods and drinks even before the age of 6 months. So this is where we have two problems. Children are not being fed complementary foods timely. So from 6 months, from the age of 6 months, but also the quality of the foods being introduced is really of bad quality. So we have processed foods and drinks and ultra-processed foods. So this is also a key challenge we need to take into account. Next slide, please. So why is the complementary feeding period so important? Next slide. So as I start saying at the beginning of this presentation, the period of the first years of life is a critical stage. A child's brain grows to 75% of an adult size, and more than 1 million new neural connections are formed every second. The height increases by 75% during this time, and the body weight quadruples. So in summary, the nutrient needs in these age groups are extraordinarily high. And another challenge we have here is that these children have small stomachs and they require frequent and diverse meals. A key element to retain here is that children between 6 months and 2 years have greater nutrient needs per kilogram of body weight than any other time in their life. So again, it's a critical stage that will impact the growth and development and also the rest of their lives. Here we can see the stages of infant and young child feeding from birth to 3 years and the proportion of nutrients provided. So we can see that from the age of 6 months, breastfeeding is no longer sufficient. Here we have in gray all the space taken by complementary foods. So this is why we suggest to start at 6 months. A key message here as well is that even if complementary feeding and complementary foods need to be started at 6 months, breastfeeding and breast milk still takes a very important place in young children's diets. So we can see here all the sections in white. So we should not forget breastfeeding support even when we have started the complementary feeding support. Next slide, please. So here we can see in these graphs that the gaps in specific nutrients are being seen starting from the age of 6 months. So for example, in this graph, we can see the energy required by age group. And we can see that before the age of 6 months, the energy from breast milk is sufficient to cover the needs. However, from the age of 6, we can see here an energy gap in white that increases when as the child grows. So this is the energy gap that needs to be filled by complementary foods. We can see a similar scenario for the iron gap. So before the age of 6 months, we can see that the iron absorbed and the needs are being covered by iron from breast milk. That is very little, but at least it contributes. And then also iron from birth stores. However, from the age of 6 months, we see a wide gap regarding the iron. This is a key nutrient, and this is why animal source foods are so important in complementary feeding. So these are gaps that we also need to fill with complementary foods. Next slide, please. We see again a similar scenario for a gap for vitamin A. So we can see that before the age of 6, the requirements, the nutrient requirements are being filled. But again, we see a vitamin A gap here in white that we need to fill. mainly with fruits and vegetables. And from the age of 12 months, we can also see gaps. This is a summary on energy, protein, iron, and vitamin A. So we see that from the age of 1, the percentage of energy and these nutrients are being, the breast milk contributes to it. However, we see big gaps here in white. And again, we need complementary foods. Next slide, please. And stunting and wasting, so acute malnutrition, are very common in this period. So these are 2 types of undernutrition. And the main causes are inadequate quantity of foods, diversity of foods, poor feeding practices. So for example, not being responsive to the child, and of course, increased infection. Next slide, please. Here we can see a global overview. So again, this is not specifically from the region, but it takes the region into account. We can see here in this box in red that stunting increases rapidly between the ages of 6 and 23 months. And this is because of key gaps we're seeing in complementary feeding and potentially also on breastfeeding. And here we see that more than half of all children with wasting are younger than 2 years of age. So again, this is a proportion globally, but it gives us an indication of the importance of this age group. Next slide, please. Other consequences of inadequate feeding practices include lack of required nutrients to meet demands, slow child development, increased risk of malnutrition and illness, digestive issues, less protective factors given that breastfeeding is decreased or stopped, and there could be a risk of aspiration leading to pneumonia or asphyxia associated with providing an appropriate thickness or texture of food. Next slide, please. Okay, so I am now handing over to Andrea, who will present us what are the challenges to complementary feeding in emergencies. Andrea, over to you.
Thank you, Yvette. Well, now we are going to talk about challenges to complementary feeding in emergencies. Next slide, please. Well, we have barriers to recommended practices during emergencies, like, for example, poor knowledge and harmful traditional beliefs, poor access to adequate and appropriate foods, also the lack of facilities and equipment for safe and hygienic preparation, eating, and storage of foods, the worsened hygienic environment, lack of access to safe water, donations of BMS and inadequate baby foods, aggressive marketing of commercial baby foods, time constraints, stress, high caregiver burdens, and a limited access to assistive products for safe and appropriate feeding for children with disability. Next slide, please. Regarding the problem with donation, this may undermine complementary feeding practices and not meet nutritional and safety standards, code labeling requirements, and may be culturally inappropriate and may undermine local food use and the recommended IYCF practices. Next slide, please. Well, with this, we have to remember that the International Code of Marketing of Breast Milk Substitutes, the code, still applies in emergencies, specifically the resolution from the World Health Assembly, the 69.9, which focuses on ending inappropriate promotion of foods for infants and young children. Next slide, please. We also have the findings from the IFE core group review on complementary feeding in emergencies. They found that the factors affecting the implementations are the coordination and leadership, the needs assessment, the funding, the supplies for complementary feeding in emergencies, the preparedness, and the partners' own perceived limitations in programming. And we're going to talk a little bit more about each factor. Next slide, please. In coordination and leadership, gaps were described in complementary feeding in emergencies coordination and the leadership at a country and agency level. In needs assessment, the decisions to intervene in complementary feeding in emergencies rarely included needs assessment. In funding, to address IYCF-E, including complementary feeding in emergencies, there is a need for a holistic funded package of interventions that includes WASH, health, and food security, in addition, of course, to nutrition. And this was not always possible due to funding constraints. Next slide, please. In supplies, the provision of a diversified diet has been very challenging. In preparedness, they identified a major gap and a barrier to effective and efficient complementary feeding in emergency response. And also partners didn't know what really constitutes an effective and efficient complementary feeding in emergencies intervention, and they did not have enough information on the how of implementing a complementary feeding in emergencies program. Next slide, please. They also found that there are existing policies and guidelines, but most of them are focused on breastfeeding and BMS. There is a lack of IYCF guidance based on complementary feeding. Also, the dissemination to frontline health and nutrition workers from government and NGO staff, including national NGOs, it was found as an important gap. And even though guidance exists on the what in the operational guidance, there is a need for guidance on the how in order to put the guidance into practice in an emergency. Next slide, please. Now we're going to see how can complementary feeding be supported during emergencies. Next slide, please. The complementary feeding supports includes the provision of education, awareness raising sessions during, for example, food distributions, or the time people wait for health attention. We also have these behavior change, problem solving skills in, for example, mother-to-mother and care groups, cooking demonstrations, and the health workers counseling. We also can provide multiple micronutrient fortified foods specifically to children aged between 6 and 23 months. The micronutrient supplementation with sprinkles for use in home fortification, and of course the nutrition sensitive programs. These are focused on improving access to safe foods for children between 6 and 23 months, and they can include cash, food aid, home gardening, WASH, etc. Next slide, please. According to the operational guidance on infant feeding in emergencies, we are going to consider the activities that we can find in the action framework to improve diets of young children during complementary feeding period. Next slide, please. Here, you can see the strategic actions delivered through systems. For example, in the food system, the health system, a WASH system, and the social protection system. Next slide, please. To meet complementary feeding needs in emergencies based on the framework, we need to first identify key aggravated drivers, like the access to adequate food, services, and practices. We also have to build a response that supports existing systems. We have to contextualize the response to maximize the results and, of course, coordinate always the response. We also have to understand the context. It's different sudden emergency than a slow onset emergency, migration and displacement, for example. Next slide, please. Contextual factors should be considered when providing food assistance. Here we have examples like the cultural and acceptability for the age group, the access to fuel, equipment, utensils, and facilities to prepare and also eat food, the access to clean water for drinking, but also for food preparation. etc. Next slide, please. Remember, do not send or accept donations of complementary foods in an emergency. Next slide, please. We might need to use commercially produced complementary foods. We have to be sure that they meet minimum standards. We would have to refer to the international guidelines on the formulation of complementary foods, for example, the Codex Alimentarius, and also we should be sure that they meet minimum standards for nutritional profile of complementary foods and country-specific standards as necessary. Here a note, the ready-to-use therapeutic foods, RUTF, are not appropriate complementary food. Next slide, please. Here we want to show you this recent example from Ukraine crisis, where the Nutrition Ukraine cluster developed a guidance for organizations supporting the feeding of children aged 6 months to 2 years in this specific context. It has many important sections. Here you can see the decision tree, where they show what to consider in the decision of food assistance options or modalities, depending on the availability of cooking equipment, access to the market, and mobility. Next slide, please. They also have in this guidance how much should be provided, disaggregating to age groups from 6 to 11 months and from 12 to 23 months. Next slide, please. They also warn with what not to include, for example, unhealthy food or powder milk or infant formula. Next slide, please. And they also explain what are the key messages to provide. For example, information of the food provided, who the food is for, what it is, what it contains, how to prepare, if in the case that they had an unfamiliar or packaged food, how to store, packet, container, and leftover food, and of course, how to serve it. And they remind us that the information should be provided in the language of the relevant population and simple, non-technical language used. Next slide, please. They also mention the additional supplies that may be needed because, as we have seen in this presentation, complementary feeding is not just related to food assistance. And they guide to provide information on services available, eligibility, and contact details, including, of course, the infant and young child feeding counseling, the support for non-breastfed infants, the distribution of hygiene items, psychological counseling, and others. Next slide, please. Now, a brief summary on preparedness per different sections. For example, here in coordination and communication, we must set up the nutrition coordination group to develop plans and actions on nutrition in emergencies. We can also prepare a draft on early communication and the key messages to donors, fundraisers, the media, and the public in general on the need to avoid donations of BMS, including complementary food, and the support to the adequate IYCF practices. In situation analysis and identification of needs, prepare or adapt survey tools, questionnaires to assess the needs and the context to support complementary feeding in emergencies. And in response planning, depending, of course, on the type of response that we're going to have for complementary feeding, we can start identifying local suppliers for CBA or food for local procurement, verify availability of facilities or the feeding equipment that we may need at the national level, and verify the viability of generic unbranded products with easy to understand instructions, remember, always in the local language. We can also draft a possible plan of response depending in the context, and we should not stockpile food before the onset of an emergency, because as we learned today, we do not have a single answer to response in emergencies. We have to assess, and after that, we can decide what kind of response we're going to have. Next slide, please. Finally, ensure that staff involved has sufficient capacity for assessment, supply chain management, and counseling. Identify and train relevant institutions and community-based health workers to ensure quality assessment of feeding practices and counseling on appropriate IYCF practices. And we can also develop information leaflets about complementary feeding. Next slide, please. Now, let's listen to Diana and an amazing case study. Over to you, Diana.
Thanks. Hi, everyone. I'm Diana. I'm the UNICEF Health and Nutrition Officer here in Roraima, Brazil. And today I'm going to share with you the experience that we had on complementary feeding in emergencies, developing a pilot project here in Roraima, Brazil. So we developed a project called Supporting the Health Feeding of Children aged 0 to 24 months living in refugee shelters in Brazil. And why we included since age 0, it's because we also considered here in our project the pregnant and breastfeeding women, considering the importance of the counseling and health feeding on this group as well. So we also included pregnant and breastfeeding women. So as you may know, Brazil is a big country. And in total, we have 10 UNICEF zone offices in Brazil, and Roraima is one of them. And Roraima is a state in the border with Venezuela. So Roraima is the main entrance of Venezuelan migrants and refugees in Brazil. And we have this UNICEF officer here since 2018, exactly because of the migration crisis in the region. So UNICEF implemented this office to deal with this emergency. In Roraima, we have refugees and migrants living inside shelters and outside shelters. We currently have 10 shelters in Roraima, and we, on average, have 7,000 people living inside shelters nowadays. We also have a lot of people living outside shelters. And our response is basically to provide services inside shelters. On health and nutrition, we are providing basically primary health care services, including nutrition, conducted by community health workers, nutritionists, and nurses. And on nutrition, the nutritionists and health and nutrition monitors are providing nutritional evaluations, micronutrient supplementation, the identification of malnutrition, of malnourished cases, and the referral treatment, and so on. And also since 2020, we are also supporting local health facilities, exactly because we are trying to reach people living outside shelters. People are living outside shelters in informal settlements, in the streets, in rented houses. So we try to support local health facilities to increase their capacity, so also to increase the access of migrants and refugees to the local services, the local health services. In Brazil, shelters are managed by Ministry of Citizenship, Brazilian Ministry of Citizenship, and UNHCR and its partners. And UNICEF is providing services in health nutrition, wash, education, protection, and so on. So on average, people stayed 4 months inside the shelters, but they can stay longer depending on their options to the future. And especially indigenous people, because we have indigenous and non-indigenous shelters, and especially non-indigenous people then can stay for years living in shelters. So it's a very complicated response. And for indigenous people, it's more complicated, their integration in Brazilian society. And that's why you have to think in other solutions, like other long-term solutions for them. Just to you guys have an idea of our situation in terms of nutritional status, we brought data here. So from between January and June 2022, we did 926 nutrition evaluations in Pacaraima, which is the city exactly in the border with Venezuela. And from these children, 10.7 had moderate acute malnutrition, 2.7 had some severe acute malnutrition, and 17.8 were stunted. Inside shelters, people live inside shelters. They receive 3 meals per day provided by the Brazilian army. So Brazilian army hired a private company to provide these ready meals to the people living inside the shelters. And so they're receiving these ready meals 3 times per day. But we observed that these meals were not adapted to young children. Meaning that the children between 6 and 24 months that were exactly in the time of food introduction, feeding introduction, health feeding introduction, they were not receiving suitable meals for them. So we observed that we had low diversity of food items. They are not considering the group's specificities, also considering here the indigenous groups, and we had also food monotony. And this caused a situation in where children were rejecting the meals, and we observed also an increasing of moderate acute malnutrition exactly in this group between 6 and 24 months of life. So we had a problem, and so we had to think in a solution or to propose a solution, an alternative solution, and that's why we developed this pilot project. So the project was focused on the provision of an alternative of supply to the food. So an alternative approach based on the provision of healthier and low-cost food. The participation of the community in this process, and to create conditions to the caregivers could support the children during this process of the food introduction. So we decided to create this project exactly to address this problem because we are observing that caregivers were distant from this process of food introduction of their children. They were not making decisions, they were just accepting the food, and these were impacting directly the nutritional status of the children and also their emotional bond. You know, the decisions that they make in their children's life were being affected of this model of sheltering. So that's why we proposed this project. The project was developed by UNICEF Brazil in partnership with AVISI as implementing partner and CREM. Also the project was funded by PRN. So the first step was to adapt community kitchens that we had inside shelters. So we bought equipment, some kitchen utensils and others. So we could have places adapted to the workshops that we would promote to the caregivers. So we started by listening, by dealing with the caregivers exactly to have an idea of their perceptions on the complementary feeding of their children. So specifically for this project, also we hired a team because we had already our team dealing with the population inside shelters, but we decided for this project to have a special team. So we hired a coordinator, 2 nutritionists, and 2 nutritional technicians. We developed their group and in a group of up to 10 caregivers, and each group attended a total of 5 meetings. The workshops were theoretical and practical, and that's why we did it inside the community kitchens. And we also applied pre and post tests to access their previous knowledge, their previous expectations, and also the impact of the workshops in their knowledge after the classes. The workshops were focused on first 1,000 days of a child, the importance of this period, as I already saw during these workshops today. on breastfeeding, food introduction, and the food guidance for Brazilian children under 2 years old. We have a protocol, a guidance, a Brazilian guidance that you also use as material during the workshops. And we finalize it with a great meal shared by all of the participants. And in each workshop, we also worked on a gift, a symbolic gift, so they could concretize the class, you know. We conducted these workshops in very practical dynamics, as I said, with the creation of these symbolic craft works, moments of relaxation, moments of meditation, mindfulness, and also to create this environment, this peaceful environment inside the shelter. It's a very busy dynamic, and we would we are trying to create a different environment so they could really be more concentrated in this important team. We also had a really special moment of a sensorial workshop with the children, in which we presented to them the foods, and we also presented the foods in different textures, colors, smells, so that we could stimulate their senses. And it was very special also to observe the caregivers' reactions, because for some of them it was the first time that their children were having contact with different foods. So it was very special and emotional moment for them as well. We also did a partnership with a private organization to develop a professional course on safe food handling practices. So for the ones, for the caregivers interested, we provided this opportunity so they could do this course and receive a certificate, and they could look for jobs in restaurants, bars, and so on. And it was also a way to facilitate their integration in Brazil, and also to create more interested in this team, their workshops and so on. We also developed workshops to health professionals, focus on health professionals, because we observed also a gap of knowledge, especially in the first 1,000 days, the importance of the first 1,000 days in the health professionals. So we also provided a special workshop focused on health professionals. And in total, we had 159 caregivers participating in the 5 meetings of the workshops, and 99 in the professional trainings on safe food handling practices. So with all this data collected, all this information collected, we developed a model, of alternative model of provision of healthy food inside the shelters, especially to this group of children aged 6 to 24 months. So we are trying to provide an alternative, and healthier alternative, in a model in which they could have access to more diversity, consider the 8 food groups that we also saw today, and so on. So the focus was to strengthen a food system to respond to the nutritional needs of young children in fragile settings in emergency. So a consultant did a map and designed a network of potential local food suppliers. So we mapped small farmers, markers. Also, we did contact with social programs that already inside the Brazilian public policies to collect ideas and opportunities and alternatives. We also did interviews with representatives of some institutions exactly to engage them with the importance of complementary feeding for these children. So here we can see a list of the type of organizations that we contacted. So in our network, we had farmers associations, university, private organizations, the municipalities, the Secretary of Agriculture, and social assistance, and also the operation itself. We had this opportunity to them of their involvement in the management of the community kitchens, meaning that they would have more responsibilities. They would have they engaged in the activities inside the community kitchens. So we would like of the if they would accept or not of their perception on this. Sorry. So after the interviews, the results showed that almost 90% of them would like to use the shelter's kitchen to prepare food for their children. 90.4% stated they would accept additional responsibility like cleaning the spaces, etc., and distributing meals. From this group, 53% of caregivers have more than 3 children, and 41% were single mothers, and 45.8% have no one to stay with their children during the activities. So these were the profile of our caregivers in general. So we developed a model based on also their willing to contribute and to participate. In this model, each caregivers would have responsibilities in the kitchen to prepare the meals based on the classes they had in the workshops for cleaning the space, and the activities would be would have a rotation among them exactly to not overwhelm any of them. And you also would have supervision of one nutritionist and one logistic technician. So would have we make sure of the quality of the activities and also to be safe for the children. We also developed a local community system composed by caregivers and focus on exactly the importance of the complementary feeding. And so it was also a matter and a way to one extra way to engage them in this such important theme as a complementary feeding. So we also did a financial assessment, and we concluded that the final cost of this alternative model would be $1.5 per child per day, meaning 40% lower than the current cost. So we proved that our alternative model will be cheaper than the current model being implemented, that will be implemented inside shelters, and that would not be effective regarding the complementary feeding for infant feeding. So we proved that our alternative model would be better in all the ways, not just nutritional, considering the nutritional status, but also in an economic way. So lessons learned, we learned that first of all, complementary feeding in emergencies must be prioritized, but must have attention from managers and so on. Must receive attention for all the reasons that we also saw today. And it's possible to propose new models, and it's possible to have positive economic legacy of the migration crisis. And we also learned that people want to be involved in their children care. So the inclusion of caregivers in the co-management of the community kitchens, in the decisions of the food, the preparation, all the matters related to the food that their children would receive during this period was very important, because we saw that they were losing autonomy, and we should create a manner to empower them, and exactly they could have more autonomy to make decisions, and they could also have more moments with their children to create more emotional bonds, and also to feel more related to their children, considering all the disruptions that the migration crisis can cause. So we, through this project, we observed that we are talking about complementary feeding, but we are actually touching in many things like important in all the health attention related to children. You know, the time and the kind of the quality of time that caregivers have with their children. Instead of just receiving ready meals, they would have time with their children. They would make decisions for them, and they would also feel more included in the process of health of their children. The sensorial workshops were really special, because we saw the power of this contact between children and food. We also had a good experience with the professional training, because caregivers felt really engaged, and also they felt like having an opportunity, a job opportunity, not just learning something important for their lives, but also having the opportunity to be integrated in the job market. And we also had a really special time in the intersectoral approach of this project, considering the WASH things, the education and health intersectoral intervention. So as key messages, we would like to highlight the potential of this organization of the network, including food producers and suppliers from the region, and the opportunity and the possibility to provide higher quality and lower cost food inside the shelters. In the context of emergencies and humanitarian crisis, it's really important to support adequate complementary feeding practices and consider the cultural specificities. So each group has different needs, and sometimes they have really cultural differences relating the country they are arriving in. So we have to be sensible to this difference and to make sure that the cultural specificities will be considered. And also, as I already said, the importance of the participation of beneficiaries in nutrition activities. So they are willing to participate, but sometimes they are not asked to. And we are not creating, sometimes they're not creating opportunities to it. So we observed that through this project, as I already said, they could be included, they could participate, they felt engaged, and they also demonstrated more responsibility related to their children. So that's all. Thank you very much. You're also available to any doubts that you may have, not just here in the Q&A session, but after that I can also share my contacts, so we can make sure that our doubts will be clarified. Thank you very much.
Thank you, Diana. In fact, we have some questions for you here in the questions and answer box. And the first would be, was this facility accessible 7 days per week?
Yes. In this model, we created a kind of calendar to cover all 7 days and to make sure that the caregivers would have the responsibility also during the weekends. Of course, our team were not working during the weekends. They're working from Monday to Friday, but we'd have not just the caregivers responsible for this facility, this space, the community kitchen we're talking about during the weekend, but also the local committee was very important to this, to monitor and to follow the activities that were happening inside this space during the weekends.
Thank you very much. And another one, was the kitchen staff financially compensated?
Not the caregivers. The caregivers were engaged like as volunteers, right? And the team were a nutritionist and a logistic technician. Yes, they were hired by our implementing partner. But this was the special, I think also the special point of this project, because caregivers were willing to participate. They wanted to be involved, and they are not asking for any financially compensation for this. They were willing to participate in the process of the complementary feeding for their children.
Thank you very much, Diana. It was really interesting, and thanks for sharing with us all this experience. Now we are going to have more questions and answers, maybe not related with this case study, but with the information related to complementary feeding. We have here, for example, should serving sizes be considered to know if the nutrient requirement is met? Yvette, can you help us answering this question?
Yes, of course. Thank you. Thank you very much, Lily, for the question. Actually, I saw several questions going on the same direction about the serving sizes, so the amounts being provided. Actually, the amounts and serving sizes need to be increased gradually. So it will start with a few spoonfuls at 6 months, then gradually increase to half a cup, 3/4 of a cup, and a cup arriving to 2 years of age. Now, it's also important to follow the child's lead, meaning, even if these are recommendations of amounts, of serving sizes, it is important not to force feed the child, but to really follow his or her hunger and satiety cues. So they will know the amount of food they need. Well, you mentioned also requirements, nutrient requirements. I think the most important part here to really cover nutrient requirements is dietary diversity. So it's really to feed at least 5 food groups out of the 8 groups to be able to cover the nutrient requirements. So yeah, this is what I would say. I hope it answers the question.
Thank you very much, Yvette. And I would like to read these other questions that you have already answered in the Q&A box, but I think it's interesting. It's the one related to the suggestion of examples of animal food suitable to start with, and your opinion on using cow milk in case of low-income families between 6 and 8 months.
Okay, yeah, thank you. Thank you for that. So yeah, that was Sherry's question. So, animal foods can be, again, eggs, fish, meat, chicken, dairy. These are all examples. So, and these have been shown to be suitable for complementary food. Regarding cow's milk, actually, you're asking specifically from the age between 6 and 8 months. And from the age of 6 months, breast milk is still a very important part of children's diet, specifically in this age. So we would suggest to continue breastfeeding if the mother is breastfeeding, given that breast milk is the safest option in resource-constrained settings. So if there are difficulties regarding breastfeeding, I think the family, well, the recommendation would be that the family seeks breastfeeding support. If the mother is not breastfeeding, so alternative feeding should be sought. So as we have seen in the previous webinar, we should explore different options. So, I mean, can be a relactation. So really supporting the mother to relactate if she has stopped. Another option is wet nursing. So maybe find another woman willing to breastfeed the child. Although this is maybe a controversial practice in specific countries. So it should be acceptable to the mother and the family. If there's possibility of donor human milk, and infant formula should be sought as a last resort. We have also seen that in emergency situation, powdered infant formula is extremely dangerous because of how it can be prepared, for example, due to lack of potable water. So it can bring a lot of risks. So this is why full cow's milk is a safer option from the age of 6 months than powdered infant formula. So I hope this replies to the question.
Thank you very much, Yvette. If I can say a little comment about the animal source foods, we can say that the egg it's a really good option because it provides more than just proteins. For example, we can find there also iron and vitamin A. And of course that it is going to be cheaper than the other options. In field, we have heard that meat, fish, and the other products may be expensive. So that's why we offer this option about the egg, because it's cheap and it's very nutritious. Thank you. And now, as I cannot find more questions here in the Q&A box,
maybe we can replay the sprinkles one.
Okay, yes, if you want. It is, what are sprinkles on the line about micronutrient supplements?
Okay, so the sprinkle is just a common name for multiple micronutrient powders that these are used for home food fortification. So they are intended to increase vitamin, mineral, and mineral intake in infants and young children, in general between 6 to 23 months, so our vulnerable group. But it can also be used with other age groups. Here we can see from preschool and school age children, ages age 2 to 12 years. So yeah, it's just a common name of multiple micronutrient powders. So a sachet with powders that we put in, for example, in a porridge, that it should be well, let's say, mixed, and then provided to the child. Then I think we have a comment regarding, well, it's not in the Q&A, but it's regarding the food groups, right? So in the English-speaking Caribbean, uses a 6 food group system that still incorporates the 8 groups identified. It is true countries have different food-based dietary guidelines using different food groups. Some countries have more groups than others. What is important to really, let's say, monitor, if you want to monitor the minimum dietary diversity in children, is to use the methodology proposed by WHO and the food groups proposed by WHO. So I don't think there is an issue in having, let's say, different food groups. It's simply a way we can evaluate dietary diversity that is being proposed by WHO.
Thank you very much, Yvette, for that. We received another question, for infants who are older than 6 months and are displaying signs of stuntness. Is there a single nutrient we can promote?
I mean, the idea again, there's not a single nutrient we can promote. It's really about, as we have said, diversity. The young children need a diversity of nutrients, and therefore a diversity of foods to be able to grow and develop. So I would say, well, first of all, we would need to continue breastfeeding from the age of 6 months, as breast milk still takes a big place in the nutrition from 6 months old, and then try as much as possible to have a diversified diet. So really having diverse food, as we have seen. So 5 out of the 8 food groups. In cases this is not possible, as we know challenges in emergencies are there, and it's not always easy to have dietary diversity. So this is where it makes sense to use sprinkles, so multiple micronutrient powders that will come with a mix of vitamins and minerals to fortify the foods, for example, the porridge of a child. So then we'll have a mix of nutrients. Over.
Thank you very much, Yvette. Yes, remembering that we have to close all the gaps that we have. We do not only have one, we have many of them. So thank you very much. Well, now I cannot see here any more questions. So I think we can continue. Next slide, please. Or the other slide, sorry. Okay, Yvette, over to you.
Thank you. So now we're going to, well, I'm not sure we had a look to at resources, but here we're providing some resources at the end of this presentation. So presentations will be shared and you'll have the resources. Next slide. Here we have, for example, resources for complementary feeding and disability, given that feeding children with disability need some adaptations. So when you will receive this presentation, you will receive the link to these resources. Next slide. So, okay, so now we're going to the next steps and closing. So please fill out a brief evaluation questionnaire. It will take 5 minutes. It will pop up when you close the webinar. Next slide. Also, if you are looking for support regarding nutrition in emergencies, for example, how to support breastfeeding in emergencies, how to support infants who cannot be breastfed in emergencies, or also support feeding children older than 6 months in emergencies, you can request support to the Global Nutrition Cluster Technical Alliance. So here is a link that will be also provided to you. So the Global Nutrition Cluster Technical Alliance provides different types of support, such as remote or in-country technical support, for example, when an emergency hits. The Alliance has also a roster of consultants, so that it can be provided to you, and you can hire him or her directly. Also, if you want technical advice, for example, a simple question, such as the ones you have been asking in this webinar, also please feel free to request support on that, and also if you want peer support. So the Alliance is here also to support you. Next slide. Okay, so this is all for today. So we thank you very much for being here in this webinar on complementary feeding in emergencies. Also, something regarding certificates. So people who have participated in the 3 webinars in the last few weeks will receive as a certificate of completion. So this is something that the Alliance will do directly. So we'll be in contact with you soon on that. We'll share the certificates. We will share the presentations as well as the responses to the questions asked, and a list of key resources regarding the 3 topics we presented today on infant and young child feeding in emergencies. So thank you again for your participation, for your interest in this topic. I hope, well, we hope it was very useful for you, and it will be useful in your current practice. And so that's it from our side. Thank you again, and please don't hesitate, don't forget to complete the evaluation form, and also to provide comments on how we could improve future webinars. So thank you again, and have a great day. Goodbye.